that's true.
No, he had his eye surgery.
Yeah, I've seen him.
Because I gotta get a little coffee.
He's getting the other eye done.
He had knee surgery.
Oh, maybe that's
the second eye?
No, maybe that's it. Maybe a second
Well,
eye.
Gary would come. Is Len, did he have a second eye done?
He had them both done, yeah.
So is he here today or is he not here?
I don't think he's coming today. He had some other reason. He was
I
going.
think he's out of
He
town.
went to San Diego or something.
Oh, his recovery.
We're still working on getting the name. There was no vascular surgeons there this weekend.
Oh,
I think they took off.
thank you, thank you.
Yeah.
She's going to see Barnard at Swedish if you can't get me a better name.
Vascular surgery?
And one of my nurses needs her aortic valve replaced. And she's
So
sort
we
of
got Erythromycin in here, huh?
Yeah, I got it.
History.
She's pretty nervous anyway.
Oh,
And now she needs an aortic valve.
Grandpa.
I think you're going to go.
Yeah,
Pretty cool.
yeah, it is. It had to wait a long time.
Oh, really?
I'll tell you something.
Anyhow, how are your girls?
Yeah, they do that at the US trying to They do the whole thing.
But we're close to.
All right, Grandpa land.
No, that's his kid. He's 15 years older than that. So, not 15.
Yeah, it's not like you leave.
You see, on
So what's the magic word for
them playing underwater, underwater hockey at Seattle University.
Underwater hockey?
Yeah, it's like you have a puck.
No, I haven't. I don't know anything. And tell you? Why were you there?
No, it was on TV.
It was on TV. Oh, that's Jack. You're good at
It
it.
was co-ed. They had a little thing, and it's underwater.
Okay, I'll ask him. It's on the news? How'd you see
I think
it?
it must have been on the news. I said, that is truly a sport. So they have snorkeling gear.
I'll have to ask him.
I watched the first half and then the first play.
Okay.
He's so quick.
Oh, that's
excited
funny.
about it.
Yeah.
He's the lead by John.
when he makes next year we're supposed to go to Lake Tahoe.
Yeah.
I have no idea. He's never talked about this.
When he would get that hand,
You know, they have this.
those guys are just
They have water polo there, but really it's him running it because no one else. Like they used to have a code. It's really fun to
That's a bit of a
do.
going.
It's interesting. Yeah, the black combination.
So
You can stay
At the
healthy.
end of the
last
glacier,
semester,
A
last
lot of
quarter,
guys
there
are
was
fall.
some kid who got his shoulder
I've been to
water polo, and Jackie would take him to the emergency room. Sit there all night with the kid.
you don't
I know,
appreciate
because
it.
he somehow.
All of this.
Yeah.
That's how
So
they
you
get
just
around.
lay it, throw it, so it pulls it
$20
back.
million bonus.
Anterior dislocation.
Raise. The only thing with that is it's guaranteed that it's a bonus. It's not like,
Heavily has got
if you get injured and they cut you, you don't have to pay them.
37
The bonus is
inches.
already
For
paid
risk.
out. But Paul Allen can take that.
yesterday.
If he wants to.
I don't know. You keep going higher, you pay fines like
48 hours.
No, it's not.
Yeah, so now they have a cap all of it.
Stevens has got it.
It's an art form.
Yeah, that's on my feet.
That was their big dog.
I'm getting it up now.
Well, I like going to
Attempting
take
to
that
go up.
too, but I think he said he I take his cut. So,
I take less, he said, but I don't want to be disrespected. That's the big word, right?
You're not, you may not be able to use
I don't blame these guys. You know, they have just a finite life.
You have to buy cool
Football, you know, running backs.
Take the
well,
shot.
that's what Drew's first cousin, my nephew, is their
Only at the company.
orthopedic surgeon for the
I don't know
front.
if you could get
And he's saying you see all the stuff that he's doing. It's statutory. That's what they're not getting to ever make much money.
They don't sell anything at the bottom.
Forget about that. On the other hand,
How, then if there's still room after the employees, I don't know how that works.
Well, there are three really good.
We got the statistics on the first month of the new year, Lactam determination. It's pretty good.
Oh, I could see that one. Yeah.
Base will be
Everybody's stuck, 'cause I think they're just not doing anything.
a little
Half my patients say, well, can you do this without a spirogram? Maybe get a CAT scan later. Sort of scary. Erythromycin. That's an antique, isn't it?
That's an old
Is that
style.
even around? You know they don't make
It's a pecker.
tetracycline anymore.
Really?
I tried to get it, and the pharmacist said they don't even make it. It's not. It's been discontinued at the manufacturer.
Really?
Not even for pets.
The tetracycline you can't even buy.
I thought they still use it for acne.
Huh?
I thought they still use it for acne. Really? They don't use it at all.
No, they use doxycycline. They don't use tetracycline for anything.
Let's get started. Mike's prepared a lot of information, a lot of research today, so let's get going. Keyword today is erythromycin. Mike is coming for his second installment of the non-beta-lactam antibiotics. This is actually the third in his series, and there's a ton of information here, so we'll get going. Mike?
Great, thanks, Kurt.
Yeah.
I'm wearing my Super Bowl gear here that I got recently. All right, so yeah, this is part 2. We did part 1 last year on adverse reactions to non-beta-lactam antibiotics. And obviously we're not going to be talking about this class, beta-lactams, and hopefully you have the handout or have access to the handout from last year, and we talked about these antibiotics last year. The goal, and it's a pretty big goal, so I don't know if we'll get through all of these, is to talk about these classes of non-beta-lactam antibiotics, adverse effects. If perchance we don't get through all of them, again, the slides are there as a reference and as a starting point if you have any questions about patients that you're seeing that may have potentially adverse reactions to these different classes of medication and antibiotics. And again, because of constraints on time, I'm going to try and focus on adverse reactions specifically and not drug-to-drug interactions, which can expand the amount of the talk. There may be some very specific instances where I will touch on drug and antibiotic interactions, but those will be few and far in between. So we'll start with macrolide antibiotics, and I guess the password is erythromycin, but in that class is also azithromycin, which is used tremendously frequently, and clarithromycin. And if we go back to the old original macrolide, it's one of the safest antibiotics in clinical use. Severe reactions are pretty uncommon. You can occasionally get pseudomembranous colitis and ventricular arrhythmias. But most of the adverse reactions to erythromycin are irritive reactions, and the irritive reactions are generally dose-related abdominal cramps, nausea, vomiting, diarrhea, and gas. They occur more commonly in children and young adults, and less commonly in older persons, and they can be associated with both IV and oral administration. Allergic reactions are incredibly rare. They can include skin rashes, fever, and eosinophilia. There are definitely reports of cholestatic hepatitis, again rare. It almost always occurs with the estolate preparation, and it's mainly in adults, not children. If this occurs, usually you'll see it about 20 days into therapy. If a patient's been treated previously with estolate erythromycin and gets it again, they may develop this syndrome much more quickly. Usually you'll see nausea, vomiting, abdominal pain, and then followed by that is jaundice, fever, abnormal liver function tests consistent with cholestatic hepatitis. Occasionally you'll also see in this patient rash, leukocytosis, and eosinophilia. Usually if you stop the drug, the abnormalities start clearing very rapidly. But again, can occur very quickly if you re-challenge that patient, so a much quicker onset of action. And the syndrome appears to be a hypersensitivity reaction to the specific structure of the estolate compound only. Transient hearing loss has been reported in association with the use of large intravenous doses of erythromycin or given in large oral doses. And it seems like the ototoxicity for erythromycin depends on the serum concentration of the drug. There are reports, rare, but reports of polymorphic ventricular tachycardia with QT prolongation with intravenous and oral erythromycin administration. Usually there's other contributing factors to macrolide-associated torsades de pointes, which usually includes the co-administration of a cytochrome P450 3A4 isoenzyme inhibitor. There's a Wikipedia if you want to look up all of those, which results in elevated levels of the antibiotic. Superinfection, especially in the GI tract or the vaginal area with Candida or gram-negative bacteria, can occur as with any antibiotic. Fortunately, pseudomembranous colitis is very, very rarely ever reported with the use of erythromycin. And then there is infantile hypertrophic pyloric stenosis has been epidemiologically linked to very early exposure of erythromycin in children. So now we'll move on to azithromycin and clarithromycin, again, medications that we more commonly use in terms of macrolide class. Fortunately, serious adverse reactions to both clarithromycin and azithromycin are pretty rare in the usual doses. The most common complaints are GI, but they usually are not self-limiting. Most people do not have to stop the medication, unlike erythromycin. They're usually mild GI symptoms. Clarithromycin often is associated with a metallic taste in the mouth, and I usually will warn patients about that, because if you don't, sometimes they'll discontinue the medication. You just have to tell them, it may give you a metallic taste, it's okay, it's going to go away, it's not serious, and it does happen a fair amount with clarithromycin. Abnormalities in liver function tests are occasionally seen in patients with these drugs, and again, there have been very rare cases also of cholestatic hepatitis with azithromycin. With very high doses of the drug, which is sometimes used to treat Mycobacterium avium complex, you can get CNS changes with tinnitus, dizziness, and reversible hearing loss have been reported. Rarely severe allergic reactions have been reported with the use of azithromycin, but that's extremely uncommon. There have been case reports of acute psychosis or mania in a few patients receiving clarithromycin. And clarithromycin in high doses in animal studies has been associated with teratogenic effects, so it's definitely not recommended during pregnancy. So I want to talk for a little bit about some of the new data that these macrolides carry a risk of associated ventricular arrhythmias. This sort of torsades de pointe, sort of prolongation of the QT interval, has generally been seen with macrolides in higher risk groups of increased age, female sex, concomitant drug use, especially cisapride. So let's see, where this data started and where it is right now. So one of the major contributors to this issue and the data appeared in May 2012 in New England Journal of Medicine, and the title was Azithromycin and the Risk of Cardiovascular Death. And it was a group out of Tennessee led by Ray et al. And they looked at a large cohort study, and they compared patients who took azithromycin to either no drug or amoxicillin treated for bronchitis or pneumonia. And they found in their study, and I'll show you the data in a second, that there was an increased risk of cardiovascular death during the 5-day course of azithromycin therapy compared to those who received no antibiotic or those who received amoxicillin. And this was a retrospective look-back study. It wasn't randomized or was controlled in any way. And the patients in this study were all Medicaid patients. That was the population database that they reviewed in Tennessee. Here's the data. Initially looking at the risk of cardiovascular death here, on those receiving azithromycin in red and those receiving no antibiotic in blue. So a couple of things. One, you'll see in the first 5 days, the risk of cardiovascular death is definitely different with an odds ratio of 2.88 and a confidence interval that is above 1, so statistically significant for cardiovascular death related to azithromycin compared to no antibiotic. The second thing I'd like you to see is that after the course of the azithromycin is done, although the azithromycin is still working on days 6 through 10, there is absolutely no risk. Basically, the hazard ratio is 0.88. You can see this line becomes essentially parallel after day 5. So you can make the case that, these people who were given azithromycin versus those who were given no antibiotic were probably sicker, or at least the clinically impression was that they were sicker, that they needed antibiotics. Looking at B, which is pretty redundant, it says the death from any cause. These were sort of attributed to cardiovascular death. Again, this is a retrospective study. You're just looking at data from, cause of death. It may or may not be correct, but anyway, it basically said the same thing. What they then did is looked at the risk of cardiovascular death of those who were given azithromycin, here we are, versus those who actually were given amoxicillin. So now you're saying, okay, well, both of these classes of patients were at least decided that they were sick enough that they deserved an antibiotic. And some of them got amoxicillin and some of them got azithromycin. Again, this is retrospective data. But basically, it shows, again, the same hazard risk here, a little bit lower, but 2.49. And again, statistically significant, as the confidence interval does not pass through identity. For the first 5 days of azithromycin, the risk was greater of cardiovascular death compared to amoxicillin. And again, after 5 days, it became parallel, and the hazard risk was, again, not statistically significant, and the same thing could be seen from death from other causes. So the conclusions of this study were that during 5 days of azithromycin therapy, there was a small absolute increase in cardiovascular death, which was most pronounced among patients with high baseline risk of cardiovascular disease. Based on this, plus the FDA meeting, Peter Hishizaki in March of 2013, so this paper was May 2012, the FDA met in March of 2013, and Peter Hishizaki, who's head of ID at Overlake Hospital, sent out an email to all staff at Overlake Hospital, which essentially, I paraphrased it, but essentially said the following. In May, New England Journal paper, I just discussed that with you, azithromycin has become the most prescribed oral antibiotic for bronchitis and pneumonia in both hospitalized and non-hospitalized patients in the U.S. The FDA reviewed this paper and other data, and in 2013, March 12th, issued their opinion and added a black box warning to azithromycin. So the current black box warning says that you should be concerned about using azithromycin in patients who already have prolonged QT interval, who have low potassium, low magnesium, bradyarrhythmias, patients with uncompensated CHF, patients on drugs known to prolong the QT interval, particularly patients on class 1A or 3 antiarrhythmics. And then he went on to say that for patients who are admitted to Overlake Hospital, we would need to have potassium and magnesium levels, correct cardiac history, and EKG before giving the first dose of azithromycin. And what was unknown to me until I got this email is that for Medicare patients, the first dose of an antibiotic whose patients being admitted for pneumonia must be given within the first 4 hours for them to meet quality measures for them to get paid by Medicare for hospitalization for pneumonia. So basically he said, I think this will be difficult, and I would recommend using doxycycline for atypical pneumonia coverage in hospitalized patients at Overlake. If you switch after you have a potassium and magnesium level, you have the correct cardiac history and EKG, and you want to switch at that point to azithromycin, that's fine. So this was an email that was sent to all Overlake staff, and Gary and Chuck probably got that as well back in 2013. Shortly after the FDA met in March, just about 1 year after that initial Tennessee Medicaid study, a Danish group published almost to the day in New England Journal of Medicine their study on the use of azithromycin in deaths from cardiovascular causes. And we'll review this study, and it came to a totally opposite conclusion. So, again, in review, the first study was a Medicaid population which showed an increased risk of cardiovascular death with azithromycin. This is a Denmark study using their total database, so not specific population of people within Denmark. And this study was accompanied by an editorial in the New England Journal of Medicine by the FDA, and I'll review that with you as well. So this is the Danish study, and what you can look at, here we go, okay. The current use, the first 5 days of those treated with azithromycin versus no antibiotic. And again, the rate or hazard risk ratio was 2.85, which was statistically significant for risk of death from azithromycin versus no antibiotic. And again, you could say these people must have been sicker if they got antibiotics versus those that did not. And that risk basically went away after very recent use or distant use. So it was only during the first 5 days. But they also compared the risk of azithromycin, in this case in Denmark, I guess they use a lot more penicillin V versus amoxicillin. And the risk of azithromycin versus penicillin V for use for bronchitis and for pneumonia was absolutely nothing, basically, versus penicillin during the course of the antibiotic. Was nothing after the course of the antibiotic, and was nothing in the very distant past. This pointer doesn't work very good, Drew. It's just and then they went to subgroups to see if they were subpopulations that maybe a signal was sent. And they looked at males versus females. They looked at age groups. They even looked at those who had a previous history of cardiovascular disease. And if you look down there, again, there was no risk of azithromycin in that category versus penicillin, even in those who had a previous history of cardiovascular disease, even in the female population where the risk is supposedly higher. So this was a totally negative study. And their conclusions that azithromycin was not associated with an increased risk of death from cardiovascular causes in general population, even those treated with a different antibiotic. So this was accompanied by an editorial by the FDA in the New England Journal. And just to review, I mean, this is a drug that's used so frequently. 40 million people in the United States, 1/8 of the population at some point has received azithromycin, either outpatient or inpatient. Again, the Tennessee Medicaid population studied by Ray showed that the risk for death, both from any cause and cardiovascular causes associated with azithromycin, were greater than those seen when patients were treated with amoxicillin. And the azithromycin-associated risks were higher in patients who had underlying cardiovascular disorders, which they felt was consistent with a drug-related arrhythmia. Again, not documented, but felt to be consistent. And then they commented that this new Danish study, based on national healthcare data, found no difference between azithromycin and penicillin V in the 5-day risk of cardiovascular death, which we just reviewed. And again, the typical, we must weigh any observed drug-associated risk versus any clinical benefit. So it's appropriate to consider that the possibility of certain offsetting benefits of azithromycin may not have been reflected in the data that was analyzed by Ray. For example, there are a number of studies saying that macrolides have an advantage over other antibacterial agents in terms of overall survival from community-acquired pneumonia. There's some recent meta-analysis saying that there is a statistically significant 25% difference in mortality among patients hospitalized with community-acquired pneumonia, favoring macrolides over non-macrolide antibiotics. So clinicians must consider the arrhythmogenic potential not only of azithromycin, but any other antibiotic that they may be treating their patients with. And then, of course, the bottom line, which is the thing you might expect to see in editorial, is the risk as well as the benefits of any antibacterial therapy should be considered before prescribing decisions are made. So that's pretty much where we stand with azithromycin. There's a signal, there isn't a signal. What population are you studying? What are the benefits that you're using to outweigh potentially that signal? So that's where we stand, but there is a black box warning. Yeah?
Did they comment on the fact that there's only that one day where the statistics make any difference, at day 5? Or did they just...
No, they I mean, if you see it, they start separating pretty quickly. Day 2, 3, 4, and 5, I think, are, it's definitely separating. and then it becomes parallel. No, but they didn't really comment. They just said something's going on in the first 5 days. But yeah, yeah, guys. Yeah, it's okay.
On the Danish study, I'm a little bit unclear. The data on penicillin says that it's the same as the azithromycin.
Correct. There's no signal basically.
And so, well, does that mean that penicillin also has this increased death rate during the first 5 days?
So I think what you can say is that both studies say that if you prescribe an antibiotic for pneumonia and bronchitis, there is an increased risk of death compared to not prescribing that. But there's probably a clinical point where someone made a decision, this person's sicker, I need to give them an antibiotic versus not. Now, did they die because they were sicker? Or did they die because they got either Pen D or azithromycin, right? So that's where the data doesn't give us any guidance, basically. Yeah.
So did Overlake change their guidelines?
Not that I never got another email. So if you want to get someone in, you're still going to need that potassium, magnesium, correct cardiac status, EKG, and it's got to be done within the first 4 hours if you want to at least start them. You can switch them, but yeah. Okay.
Mike?
Yes.
Just getting back to garden variety allergy, for patients who report sort of a questionable history of Weiss allergy, for example, you just progress into an oral challenge in those cases?
Yeah, I usually, since there's the history is very important, and if they come to you with a rash or symptoms that do not seem in your history to be life-threatening anaphylactic type history, and since there's no skin or serologic data to help us, I would, if I felt this patient warranted or needed or for their best interest would be nice to know if they really could take it or not, I would proceed with the graded oral challenge. Okay. Clarithromycin. So Erythromycin came out, pre-marketing stuff said it looked pretty similar to the other macrolides. It should be okay. It has a little GI symptoms, otherwise looks okay. There was a little bit of pseudomembranous colitis, a little bit of other stuff, but looks all right. But in 2006, after the drug was out, some serious hepatotoxicity felt to be likely related to erythromycin was reported. One died and one required liver transplant. Subsequent reviews by the FDA post clinical approval showed that there were, in fact, a lot more reports of severe hepatotoxicity. And as a result, the FDA put a black box warning on and also raised sort of the indications or narrowed the indications for erythromycin to serious pneumonias, basically. So there was found to be, in 2005, excess 82% risk of hepatotoxicity with the use of erythromycin compared to other macrolides. Also, in early 2000s, there was reports initially out of Europe showing severe exacerbations of patients who had myasthenia gravis who were given erythromycin, including one death, which also led to a new drug warning in European physicians calling for extreme caution of the use of erythromycin in patients who had MG. And it seems like patients who have myasthenia gravis experience worsening dyspnea and muscle weakness usually within hours of starting erythromycin. So the actual reason or cause or physiology of that is unknown. But again, a new black box warning was added that someone with myasthenia gravis should never receive erythromycin. So it's a drug that basically is not used anymore. So let's talk about fluoroquinolones. We see them a lot. We use them a lot. They're given as samples sometimes in our office. So they're definitely useful medications to have around. Most frequent adverse effects with fluoroquinolones, and there is a whole laundry list of issues that we need to talk about, but the most common are GI effects, which occur between 3 and 17% of patients. Most of the time, they're mild and usually don't require discontinuing the medication. Diarrhea is less frequent, and fortunately antibiotic-associated colitis is extremely rare. Most of the current quinolones have little or no effect on the anaerobic bowel flora, and that may be why they tend to not cause pseudomembranous colitis very much at all. The next most frequent category of adverse effects is CNS effects, and that can be, depending on the study and depending on the particular fluoroquinolone, between about 1% and 11% of patients. And patients may complain of headache, dizziness, insomnia, and alterations in mood, particularly stimulation of the central nervous system, and often they'll complain of vivid dreams. And I usually will mention that to patients who I'm prescribing a quinolone, that this may make you feel a little hyper, and it may cause some vivid dreams. If it gets past that, let me know. Because rarely you can get hallucination, delirium, and even very rarely seizures. In the studies where they have seen seizures, usually there was concomitant sort of factors, particularly patients who are on theophylline or nonsteroidal anti-inflammatory medications, which were felt to augment the ability of quinolones to displace GABA from its CNS receptors and really increase that CNS stimulation, leading past just feeling jittery. Allergic and skin reactions have occurred in small percentages of patients in clinical trials. The rashes are generally pretty nonspecific. With gemifloxacin, rashes developed in 2.8%, which is on the high side in clinical trials. But when they came out of clinical trials and were actually prescribing them in young women, for 7 or more days, self-limited maculopapular rash was reported in 14% of young women on this particular fluoroquinolone. In patients who had a shorter course of this antibiotic, 5 days or less, the rash occurred much less frequently. Phototoxicity has been reported uncommonly, but has been seen in patients exposed to UVA light. And were more frequent in these particular fluoroquinolones, which are not available in the United States, so you don't have to worry about it. Drug fever, urticaria, angioedema, vasculitis, serum sickness-like syndromes, and even anaphylactoid reactions have been reported, but fortunately are pretty uncommon. Reports of acute interstitial nephritis, likely allergic in origin, have occurred infrequently, and usually you'll see eosinophils in the urine, but not crystals. In patients who have had biopsies, there are infiltrates of lymphocytes and eosinophils in the renal interstitium in these cases. Fluoroquinolones can be ocular toxic, including retinal hemorrhages. They have been found to, or postulated to, exert those effects because of effects on connective tissue and collagen. There may be sort of compromise of connective tissue in the eye, and it may increase the risk of retinal detachment because of that. And there are basically, although this is a very rare occurrence, there is a 5-fold higher increased risk of retinal detachment in fluoroquinolones compared to non-use. But again, you know, a small signal, but definitely an increased risk. Cartilage erosions and non-inflammatory effusions occur in weight-bearing joints of juvenile animals that have been given quinolones. I think we're familiar with that. But as experience using quinolones in children have increased, particularly in children with CF given Cipro, and some children initially with recurrent otitis media or in studies with gadafloxacin. These children and others receiving Cipro did not generally have any joint symptoms, and the few who did, they were all reversible when the antibiotic was discontinued. Studies to identify subclinical cartilage damage by MR imaging of joints in treated children have all been negative, fortunately. There are certain quinolones, pifloxacin, however, arthralgias and joint swelling in kids with CF were fairly high. That, again, is not a fluoroquinolone that is currently used in the United States. So because of concerns about cartilage toxicity in children, quinolones have not been recommended for routine use in pediatrics. But there is an evolving view based on the absence of, for most of the quinolones that we use in the U.S. for arthropathy over decades of quinolone use that in some children, particularly those with CF, the benefit of the quinolone may outweigh the theoretical risk of cartilage damage, particularly for short-term use. And so expanded use of quinolones in pediatrics is certainly under consideration, but generally is not approved at this point, although still very often used in patients with CF or recurrent respiratory infection. Tendinitis with tendon rupture, definitely reported, fortunately uncommon, but definitely reported in adults given various quinolones. The Achilles tendon, the biggest tendon, is most often involved, and symptoms can occur after the completion of quinolone therapy. The highest risk seems to be the elderly, patients who are also on steroids at the same time, and patients who have received organ transplant recipients. Toxicity mechanism is uncertain, but exposure of cultured tendon cells to Cipro has been associated with increased risk of expression of matrix metalloproteinases and cellular apoptosis. Good. So quinolones to varying extents, and this is a pretty common picture we're sort of painting for just about every antibiotic, can block potassium channels and may delay repolarization of cardiac tissue, and in the right situation may prolong QT interval. And this again can predispose the patient to Torsades-de-Pointes arrhythmia. It has about the same risk as those seen with erythromycin. Gripafloxacin, which again is not available in the United States, seems to prolong the QT interval much greater extent and was withdrawn from clinical use after there were higher numbers of cardiovascular deaths than seen with other quinolones. So although the QT interval is lesser magnitude seen with gatifloxacin and moxifloxacin, arrhythmias have not been reported generally with these quinolones, and generally we don't see even the prolongation of QT interval with levo or ciprofloxacin. Again, slightly with moxifloxacin, although really cardiovascular events have not been reported with moxifloxacin, even with the slightly increased prolongation of the QT interval. Again,
would you use Levaquin in a person with QT, prolonged QT?
Would you?
Yeah.
Just about every antibiotic has this risk. So I think you end up potentially being stuck a little bit because just about everyone I've reviewed has this risk to some degree or another. I think you have to be aware of it, and if you feel like they need an antibiotic, use it, but you might really push hard to not give that patient who has a chronic prolonged QT interval antibiotic unless your back's up against the wall. Yeah.
Mike, what's the risk of ventricular arrhythmia in a group not taking any antibiotics? 3 out of 750,000 seems like a pretty low rate.
I don't know. That's a good question. I don't know that. All that we can say is like going back to, let's say, the Azithro data. Given Azithro or not given Azithro, there was a signal basically. So it's above whatever that background noise is. It seems to be. But again, the risk of not giving an antibiotic when you really need one is death also. Could be potentially morbidity and mortality. So again, the story is very similar. I don't want to beat a dead horse. If you have this risk, it goes up if you're on certain particular other medicines that may also prolong the QT interval, or if you have low potassium, low magnesium, uncompensated CHF, bradycardia. So all of those risks are across the board for any medication that can potentially prolong QT interval. Leukopenia, eosinophilia generally occur very rarely, less than 1% of patients, and you can see mild elevations in serum transaminations. Again, 1 to 3% of patients receiving quinolones. Very rarely does this require stopping therapy. Usually those are low levels of rises, and they are reversible once the 10, 14-day course is completed. Exceptions to this is a quinolone called trovafloxacin, which was associated with elevated transaminases in 1 out of 10 patients receiving a 4-week course for prostatitis. And then there were also reports with this particular quinolone of a rare idiosyncratic hepatitis, post-marketing surveillance. Some were also associated with eosinophilic infiltrates in the liver and liver failure, and some required liver transplantation, and this led to the ultimate removal of trovafloxacin from clinical use. In a similar sort of set of circumstances, temafloxacin was found through again, most of these are post-marketing. You probably don't want to be the first person receiving any medication as it gets through clinical studies, but so much of the signal is missed with a few hundred people. But after its first release, temafloxacin was associated with rare cases of hemolytic anemia, thrombocytopenia, and renal failure with an incidence of about 1 in 5,000. And this again led the manufacturer to remove temafloxacin from market. So why those two particular have a much higher incidence of some pretty serious effects are unknown, but they're no longer for your use. There have been occasional reports initially of hypoglycemia associated with the use of Cipro, Levo, and moxifloxacin. There started to be much more significant reports and much more severe hypoglycemia that was associated with gatifloxacin in diabetics on oral hypoglycemic agents initially. Modest reductions of glucose and increases in insulin were also reported in a study using gatifloxacin in diabetics that were not even on hypoglycemics. And then interestingly, there were even reports of hyperglycemia with this particular quinolone, gatifloxacin, or Tequin. And because of these really strange fluctuations and effects on serum blood sugar, eventually gatifloxacin was removed from the market as well. So Tequin, which was in our offices for a while, is no longer there. Safety in pregnancy has not been established really for any of the quinolones, but they have data on studies of babies who were born to women who were exposed to certain quinolones, Cipro being one of them, norfloxacin another, during the first trimester. And there was no increased risk identified of teratogenic issues. And it was interesting, there was one study where they did a case control study comparing 200 women who were exposed to fluoroquinolone versus 200 women who were exposed to a non-embryotoxic antibiotic during pregnancy. And there were no differences in birth defects, there were no differences in spontaneous abortions, prematurity, any fetal distress, but there was a higher risk of therapeutic abortions in those women on the quinolones, suggesting that either their or probably their providers' concern about fluoroquinolone led to them having a therapeutic abortion because of concern about a potential teratogenic effect that probably is not there. Quinolones are excreted in breast milk, and they should be avoided for nursing mothers. So we're going to switch gears from now the quinolones. And, yeah, Paul.
With the quinolones, did anybody look at it scientifically to try and figure out what was the mechanism for these reactions? Because obviously the base molecule is the same, and all these other molecules have side chains and different stuff. Did anybody actually look?
No, they haven't gotten mechanistically as to why this quinolone has such a high incidence of hepatic failure, why this particular quinolone has such a disruption on blood sugar metabolism and pancreas.
So once they decide to pull them, they just quit.
Yeah, I mean, they don't study them once they're they're pulled. I mean, yeah, typically not. So, clindamycin. CDC reported of emergency department visits in the mid-2000s for antibiotic-associated adverse reactions. Those associated with clindamycin were among the highest, with over 18 visits per 10,000 outpatient prescriptions. Allergic reactions are pretty rare, but they have been reported. Obviously, the big thing with clindamycin is GI diarrhea in upwards of 20% of patients, and it's more common with oral administration versus IV administration. So the major toxicity and that limits their more frequent use is the occurrence of pseudomembranous colitis caused by obviously toxins of C. difficile that overgrow the GI tract in the presence particularly of these clindamycin, lincomycin antibiotics. Now, antibiotics other than clindamycin, particularly cephalosporins and fluoroquinolones, have become more frequent causes of C. difficile, but that's because they're used so much more. If you look at clindamycin per use, it is far and away the most common antibiotic to cause C. difficile overgrowth. But you see it more in these others because they're used so much more commonly now.
Do you have incidence figures that you can compare, like the kind of anaphylaxis to beta-lactams is what, 1 out of 30,000, 1 out of 50,000? Any kind of similar figures for these other drugs, well, for clindamycin, for example?
For anaphylaxis?
No. The incidence of pseudomembranous colitis compared to the incidence of anaphylaxis and penicillin.
Well, 20% in clindamycin, they discontinue the use because of GI symptoms. Now, probably not all of them have C. difficile at that point, but they have bad enough diarrhea that they want no part of that medicine. So it's pretty high. So 1 in 5 are going to say, I can't take this drug. So going on to vancomycin, ototoxicity has been definitely reported. It seems that it's seen much more when you have higher levels, particularly in the trough levels of 19 micrograms per ml or higher. And it has been associated with high-frequency hearing loss of about 12% and much more common in elderly patients. When ototoxicity develops, it's usually reversible after the drug is discontinued. And often your patients will tell you, if you're listening, that they are feeling or hearing a little ringing in their ears or developing a little dizziness. That often will precede the reported hearing loss or the found hearing loss. Most prospective studies found that there's a small risk of renal function impairment with the use of vancomycin. It seems to again be associated with trough levels that are at least 15 micrograms per ml or higher, or if they're also on other nephrotoxic agents such as aminoglycosides, etc. And synergistic nephrotoxic effects definitely have been seen in animal studies between aminoglycoside and vancomycin. So if you on both of those agents, the risk goes up to about 20% in terms of nephrotoxicity. Rarely, acute interstitial nephritis has been associated with vancomycin use. And then probably the most common side effects and ones that often we are called to consult on or talk to colleagues about is the infusion-related reactions. There's a rapid onset of an erythematous rash, pruritus, often head, face predominant, but it can be all over, sometimes associated with angioedema, occasionally if severe, associated with hypotension, known as the red neck or red band syndrome. It's been reported during infusions of vancomycin with a frequency, depending on the study, between a little over 3% and a little over 11%. And again, in rare cases or severe cases, hypotension and even cardiovascular arrest have been reported during vancomycin infusion. The mechanism of this is probably related to drug-induced histamine release from basophils and mast cells. And the reaction subsides almost immediately after stopping the infusion without any other therapy, although often we're thrown antihistamines at that patient at the same time. And usually you can prevent these reactions by decreasing the infusion rate the next time you're going to give vancomycin and by pre-treating with antihistamines. Local reactions, phlebitis is pretty high with vancomycin, and that's why often we don't also like to use it if we can avoid it, but it's as high as 14% of patients receiving vancomycin will get a isolated phlebitis in the vein that it's in. Neutropenia is observed with vancomycin with a frequency of about 1 to 2%. Rate increases upwards of about 12-13% who are patients who are receiving long-term vancomycin therapy. And the neutropenia usually resolves after discontinuation of the drug. If you need to have a patient on vancomycin long-term for greater than 2 weeks, it is recommended that you monitor CBC to check for neutropenia. Thrombocytopenia, very rarely reported. When it is seen, it's definitely associated with platelet-reactive antibodies. Have been found in most of the patients who have thrombocytopenia. So obviously, immune-mediated destruction of platelets. Occasionally, that can lead to significant bleeding, and occasionally there have been reports of very significant drops in platelets within the first 24 hours of the first infusion of vancomycin. So that person probably had antibodies that were ready to go. Presumptive vancomycin-induced maculopapular or erythematous skin rashes and drug fever are noted in a small percentage of patients. Cases of more severe reactions such as erythema multiforme, toxic epidermal necrolysis, linear IgA bullous dermatosis, and Stevens-Johnson's have been reported, but they are fortunately pretty uncommon. Despite the clinical use, as we know, vancomycin is often used for severe C. difficile-associated disease, pseudomembranous colitis. There have been reports that vancomycin in certain patients has actually induced C. difficile overgrowth, but pretty rare. It's sort of typically the second-line agent, Flagyl being first. If they fail Flagyl, then typically would go to vancomycin. So sulfonamides can cause a whole host of problems. As many of you are aware, you've probably seen many of them yourself and asked to consult. You can get GI symptoms, you can get rashes, fever, you can get hepatic issues, you can get lupus, you can get serum sickness-like reaction. High doses can be associated with crystals in the urine and tubular deposits of sulfonamide crystals. These complications can generally be minimized if you increase urine flow, drink a lot of fluid, or increase IV rate, or alkalize the urine. Acute pancreatitis has been occasionally attributed to acute use of sulfonamides. More serious reactions can include acute hemolytic anemia, sometimes related to deficiency of glucose-6-phosphate dehydrogenase. They've also been reports of aplastic anemia, agranulocytosis, thrombocytopenia, and leukopenia. Sulfonamides, as you may know, should not be administered during the last month of pregnancy. They compete for bilirubin binding sites on albumin, and it may increase the fetal blood levels of unconjugated bilirubin, which increases the risk of kernicterus. Again, significant hypersensitivity reactions do occur with sulfonamides given anyway, orally, intravenously. E. nodosum, E. multiforme, Stevens-Johnson, fixed drug eruptions, vasculitis, and anaphylaxis have all been reported with sulfonamides. Even topically applied sulfonamides have been associated with any of those reactions. Patients with HIV have a tremendously higher risk of those sort of adverse reactions to sulfonamides. It's unclear why, except something about those abnormal lymphocytes make them more prone to reactions to sulfa. So very briefly, I think we'll conclude, with this class with this trimethoprim sulfamethoxazole. So all of the effects that we just talked about sulfonamides are included in here, but now we have some additional effects because we're adding a second antibiotic, trimethoprim, into the mix. So the additional side effects will be related basically to trimethoprim. You can get issues with folate use, and so you can sometimes see megaloblastic marrow with hypersegmented polymorphonuclear sites. You can see leukopenia, thrombocytopenia, granulocytopenia, sometimes with fatal results. Studies have suggested this occurs in about 1 per 18,000 prescriptions, and older patients are at higher risk. The administration or co-administration of folic acid usually prevents folic acid-related issues from occurring, and the antibacterial effects of trimethoprim are not blocked by co-administering folic acid. Pseudomembranous colitis has been described, but it's very uncommon. Renal dysfunction may occur in patients who have pre-existing renal disease, but again, usually uncommon and usually reversible once the medication is discontinued. You can see hyponatremia and hyperkalemia, usually in very high doses and usually in patients who have underlying renal insufficiency. And trimethoprim sulfamethoxazole may in itself cause some increased levels in serum creatinine. Interstitial nephritis attributable to TMP SMX has been described in transplant recipients and patients with AIDS. And renal tubular acidosis is uncommon but has been reported in children undergoing treatment for ALL. Cholestatic hepatitis has been reported. Pulmonary hepatitis and pancreatitis have also been reported. And very rarely meningitis and meningoencephalitis have been described in patients on TMP SMX. Very rarely anterior uveitis and retinal hemorrhage have been described with trimethoprim, and seems to have a reversible myopathy, and acute angle closure glaucoma have rarely been reported. And acute psychoses have been very rarely reported with trimethoprim as well. Unknown mechanism. I don't think there's probably time to go into nitrofurantoin. It's here, I think, as reference for everyone. I think the main issues just with nitrofurantoin by far pulmonary reactions that are categorized into acute, subacute, and chronic, and the data is sort of here of how those behave and what the issues are. Very rare other reports of nitrofurantoin. We don't get involved too much with nitrofurantoin, but it's here as a reference. And then these are my 2 dogs at home who are relaxing in what was sun a while ago. So thanks for your time, questions, or this is really just here as a reference, I think, because it's a lot of lists of things, but it's important to know the highlights of the drugs that you tend to use, and certainly be aware of the potential risk of patients you may be asked to consult on. So I think we've completed most of the non-beta lactam. I think we've done the beta lactams before, so we'll see what Len comes up with next year related to drugs for me.
Do you feel comfortable testing all these drugs? I know the literature is getting more and more sketchy about which ones they think we can actually test for accurately.
So you're talking about skin testing?
Or any kind of biologic or skin testing.
Yeah, I think we're still pretty in the dark with most of tests, for antibiotics. So again, when we're testing, whether it's serologically or skin test-wise, most of the time we're talking about IgE or anaphylactic type issues. So as you know, we have, penicillin. There is certain non-irritative concentrations of native structures of cephalosporins, that are reported. We have some others that are reported in non-irritative concentrations, but we don't know the metabolic pathways of many of those. So a positive sort of helps us as long as we're under irritative concentrations. A negative, depending on the history, is, again, I think the history is still the most important thing. So the truth of the matter is, doing this for a pretty long time, if someone comes in and tells me like a really scary story that I believe, that is not sort of made up or isn't, somewhere out there, and I do penicillin testing and they're negative, I'm still cautious with that person. I will administer that medication very cautiously the first time, even with negative skin test, if that history is great. And of course, most of the histories we get are sort of vague, or they're not even histories. I don't know. I was told, or I had some or the history is such that you know it's a side effect. So in those cases, if there's no skin test material, I think the best thing to do, if you find you need to expand the antibiotic repertoire of that individual, is to calmly sort of talk to them, because they're usually revved up. They have this laundry list of antibiotics that they're pretty nervous about. And so you have to start the process maybe even a couple of visits before you do the challenge. We do this all the time. It's always safe. We're here if anything happens. And then you do your graded oral challenge, 1/100th, 1/10th, 9/10ths the dose, sit there, everything's okay, you can take this antibiotic moving forward. There are some people out there who do placebo challenges when they tell them they're doing the real stuff because they're so convinced they're going to have a psychologic reaction. So you can debate the ethicality of that, but people do have adverse reactions to sugar tablets when they believe they're being given, azithromycin that they've had a terrible reaction to. So, and then once you pass that oral challenge, most of the time I find patients are extremely relieved and will, accept the antibiotic, but still, sometimes they pass an oral challenge and you may prescribe it 8 months later because there's a need, or their PCP may, and they still will tell you, I had that same vague, goofy, didn't feel good, headache, felt terrible sort of reaction to it. So then we may do another oral challenge. So, yeah. Great. Well, thanks for your attention. Drew ran off, but I assume this is his laptop.
HIV patients.
No, I think it's through here.
It just stays there?
I'm pretty sure.
Okay, perfect. Okay.
Yeah, no. I can text it.
Okay.
It does stay here.
Okay. All right, erythromycin.
Very
But I mean, I really couldn't have had a reaction. But it's usually HIV folks. It's nice. Nice. That's it.
You would do it?
No problem. No, sorry, I couldn't be down there. At least
Yeah.
Which I didn't mention it.
Going the wrong way.
Yeah, I think so. If you just have to monitor it. Exactly. And preferentially, use the shortest course possible.
I was trying to say.
No problems there, Dave.
Howdy.
Hey, how are you?
Good. Say, amoxicillin rash.
Yeah.
What's the rate of just on the non-IG rash?
Sort of macular papular.
Yeah, just that flat, non-issue rash.
And then what is the repeat rate?